Sir, we are live.
So good evening, doctors and all the participants. Aishman on behalf of Shield Healthcare from Angelo Division. We are pleased to welcome all in today's session on epileptic spasms, West syndrome, and our guest speaker is Dr. Sai Chandra Reddy, sir. So first of all, I would like to convey our sincere thanks to sir for his valuable time to talk on this very important topic on our platform Shield Connect. And now it's time to introduce Sir, although we know Sir very well, but it's my formal responsibility to introduce Sir. Sir, it is MD Pediatrics, FIPN from AIMS Kochi. Sir is a consultant pediatric neurologist, and Sir is from Warangal. So within this short introduction, I request Sir to take over the session. And meanwhile, I request all the participants who have joined from Facebook. So if you have any query, you can obviously put your questions in the chat box of the page, so that after the session, we can have a short discussion on this topic with Sir. So thank you very much, Sir, once again for your valuable time on Shield Connect. And over to you, Sir, for further proceedings. Thank you very much.
Sir, good evening, sir.
So, are you able to see my?
Yes, sir. Visible, sir. The screen is visible, sir.
On full screen?
Yes, sir. Full screen is visible.
Yeah. So, good evening, everyone. So, I am Dr. Sai Chandra Reddy, pediatric neurologist. So, consultant pediatric neurologist at Dr. Sai Chandra Child Neurocare, Hanamkonda, and Star Children's Hospital at Karimnagar. So, today I am going to discuss about the epileptic spasms and West syndrome. So, this December 1st to 7th is the Infantile Spasms Awareness Week. So, that's why on the occasion of this week, I choose this topic to discuss with my colleagues and my friends. So, this is the epileptic spasms. So, I am going to.
Slides are not visible, sir.
There's some problem, sir. You can unshare and.
Now?
Yes, sir. Now it is visible, sir.
So now is the slide is showing case scenario only, na?
Yes, sir.
Yeah.
Sir, at the full screen, let's, sir.
Yeah, I will go through that.
Yes.
Now full screen?
Yes, sir.
Yeah.
Yes, sir. Clear, sir.
Yeah. I'm going to give one case scenario, simple classic West syndrome case scenario. So 9 months old female child delivered by normal vaginal delivery, and on the day 4 of life, child have seizures, and that is the underlying cause of the seizures is the hypoglycemia. So underlying cause of the seizures is the hypoglycemia. Yet now 9 months of age, child have the developmental delay. So around the developmental age is around 5 months only. So parents noticed since last 1 month, parents noticed some paroxysmal events is there. These events is characterized as sudden flexion of all 4 limbs with some head drop. So these paroxysmal events are more during awakening from the sleep and then the clusters. So initially they think of these are all while child is awakening from sleep, child is afraid, that's why these movements is there and they neglected. But after 1 month, they noticed that previously child able to recognize the parents. Now the child lost this visual fixation and become more irritable and sleepless. So this is the classic presentation of the spasms with child have the spasms since 1 month. So they neglected because unaware of this epileptic spasms, and child have the already developed development regression is there. So now they consent. This is the classic presentation of the epileptic spasms or West syndromes. So brief history about the West syndrome. In the 1841, around 180 years back, that British surgeon wrote the letter to the Lancet journal about his son. His son has some atypical spasms presentation is there. So he wrote about complete description of his son's clinical spasms to the Lancet. After around 120 years in the 1960, Gestalt is the who is the pioneer in the epilepsy. So we all know that is Gestalt, Lennox-Gestalt syndrome and Gestalt syndrome, the initial classification of the seizures and in the name of Gestalt. So he named this spasms presentation as the West syndrome. Almost even after 180 years of this first description, we still don't know complete understand of the West syndrome or infantile spasms. So many clinical trials to find out the cause for the spasms and to treat the so many clinical trials, treatment trials also going on. So this is brief about the history. So what is the clinical presentation when these spasms can present? So name itself is infantile spasms is there. So in the infantile epilepsy means less than 1 year of age. So approximately 30% of all cases of infantile epilepsy related to West syndrome or infantile spasms. So almost 30% means big huge number. So incidence is 1 in 3,000 live births only. What is the common age of presentation? In our clinical practice, very common age of presentation is around 6 to 9 months of age. But we can see as early as 1 month of age, sometimes up to the 18 months of age is also there. So West syndrome, classic triad of West syndrome, any our textbooks or pediatric textbook describe the classic triad is epileptic spasms and growth regression or psychomotor retardation and hypsarrhythmia on the EEG pattern. Very fancy name, hypsarrhythmia. So diagnose this West syndrome, we need to fulfill the two of these criteria is there. But in the last so many years, there is so much of research on the infantile spasms, epileptic spasms, and West syndrome. So many underlying causes, genetic causes, and structural abnormalities find out. After that, so all these infantile spasms groups is considered as the infantile spasm spectrum. So this West syndrome is the one of the part of the infantile spasm spectrum. Previously, we have the only West syndrome because hypsarrhythmia pattern is there. We can call as the West syndrome. But now we have the finding EEG. We can find out the other EEG findings also. So now they named as the infantile spasm spectrum disorders. So I am going to describe what are the clinical spasms. Classic spasms. There is the sudden, brief, synchronous movements involving the head, trunk, limbs. That is synchronous movements, or sometimes only individual alone movements can occur. So these movements is very fraction of seconds, like electric shock like movements. That is 1 second. So 0.5 to 2 seconds, this movement will occur. Typically, they are occurring in clusters. Clusters means while child is awakening from the sleep, when going into the sleep, so the child has sudden jerking of movement. One jerking of movement is there. Initial days only 1 or 2 moments is there. In each event 1 or 2 events is there. While child is time is going on for day 1 to 12 clusters of the day. In the each cluster, so 5 to 10 or sometimes 20 spasms also there. So age is increasing, days is increasing, the spasms will increase, clusters will increase. And classic type of clusters, so we can use the word of salam attacks. Very fancy word is the salam attacks. When there is all flexion of the limbs, head, upper limbs, lower limb, and trunk. That is, we can call as the flexor spasms and salam attacks. But in the clinical practice, we can see the mixed type of spasms. That is depending upon the position of the baby. If baby is lying down on the prone position or like sitting positions, we can see mixed type of spasms. After that, extensor spasm, sudden extension of all 4 limbs and neck, and flexor spasm. Sometimes we can see synchronous or symmetrical spasms or asymmetrical spasms. If any tuberous sclerosis child has some abnormality in the one side, we can see asymmetrical spasms. Means one side of upper limb, one side of lower limb, okay, involved only. So these are the classic description of the spasms. Sudden current-like movements, all the flexions or all the extensions is there. So subtle spasms. What is the importance of subtle spasms? Subtle spasms, some child have simple head nodding or shrugging out the shoulders and some facial grimacing, some abnormal movements, grasping type of movements is there. These are the subtle spasms. When any parents or any clinician notice these subtle spasms in the high-risk kids means anyone have the bad NICU stay. So in that patient, high-risk kids with the subtle spasms, we need to find out early identification of these spasms with the EEG. So at that time, subtle spasms is there, high risk is there, we can go for the EEG. We can identify it very easily. Other terminologies are infantile spasms and single spasm variant. In some kids, they have single spasm only. So daily, so multiple times only single spasms is there. Or any child with treated with the ACTH or since after treatment, they can have the single spasm. This is called as single spasm variant. So what is the difference between infantile spasms and epileptic spasm? Infantile spasms, these spasms occurring in the infants, that is infantile spasm. Epileptic spasms, these epileptic spasms may be part of the West syndrome or not. So epileptic spasms means clinical spasms with abnormal epileptiform EEG. When we call the West syndrome, so epileptiform spasms with specific pattern on the EEG, that is hypsarrhythmia, its variants, at the time only we can call as the West syndrome. So epileptic spasms are part of the West syndrome only. So now these are the classic terminology about the clinical spasms and infantile spasms and West syndrome. So what are the causes for this West syndrome or epileptic spasms? So divided into two types, symptomatic and cryptogenic. Symptomatic West syndrome means we are able to find out the underlying cause. That may be structural cause, that may be genetic cause, that may be metabolic cause. We can call as the symptomatic West syndrome. Cryptogenic West syndrome. Even after so many investigations, we are unable to find out the underlying cause. That is called as the cryptogenic West syndrome. So in the research, there is cryptogenic West syndromes are well respond to the treatment and they can respond early to the treatment. This is the importance of cryptogenic versus symptomatic West syndrome. Most common causes are mainly is neonatal hypoglycemic brain injury. So that's why very important to prevent the hypoglycemia during the neonatal period. So we need to concentrate on the feeding practices first 7 days of the life, very important. So after that, one is the HIE, hypoxic ischemic injuries during the newborn period, and well-known diseases like tuberous sclerosis complex. Tuberous sclerosis complex and epileptic spasms are very well related, and Down syndrome kids also have the epileptic spasm. So common causes are neonatal hypoglycemic brain injury, hypoxic brain injury, and tuberous sclerosis. But we have so many very big list of underlying causes for the West syndrome. That chromosomal or genetic abnormalities I explained about the Down syndrome, Miller-Dieker syndrome, X-linked infantile spasm syndrome, and cortical malformations. So the development cortical malformations like lissencephaly, pachygyria, polymicrogyria, icarditis, corpus callosal agenesis, or any cortical malformations can also present with the West syndrome. And hypoxic brain injuries, congenital infections like torch infections, and inborn errors of metabolism like organic asthenias or aminoacidopathies, pyridoxine dependency, some mitochondrial disorders. This is the very big list. Perinatal, especially perinatal means I already described that hypoxic ischemic injury, hypoglycemic brain injury, or meningitis, encephalitis, any IVHs. These are the perinatal disorders. Postnatal disorders, even after the postnatal also, if baby any have the encephalitis, in meningitis, these are all causes. Some neurodegenerative disorders like leukodystrophies also cause these epileptic spasms. There is very big list is there. After the development of the genetics, we are finding the so many genetic underlying mutations as CDKL5 mutations, ARX mutations. So we are able to find out the underlying cause for this West syndrome. So anyway, anything is there, our importance is find out the symptomatic and cryptogenic. If symptomatic is there, if treatable causes is there, we can go according to the treatable cause. Like pyridoxine dependency is there, B6 is useful, or pyridoxyl phosphate is useful. Some aminoacidopathies like that is we can go according to that. So what is the exact pathophysiology of these epileptic spasms? There are several hypotheses proposed. So some hypotheses are proved, some hypotheses have evidences, some hypotheses don't have evidence. So these are the some hypotheses proposed up to now. So one is the brainstem dysfunction. That brainstem dysfunction due to either disruption of serotogenic neurons or abnormal interaction with the brainstem and cortical abnormalities. Second thesis is abnormal cortical and subcortical interactions. One immunological dysfunction, also one proposed theory is there, but well accepted theory up to now. So many are some evidence is there. That is the fourth theory. That is alteration in the hypothalamic adrenal pituitary axis theory. So this theory is very important. We have the evidence, and our present day's treatment modality is depending upon this theory only. So during the early development, that may be during the fetal stage or early development neonatal stage, due to variable stresses like cortical malformations or HI or hypoglycemia, there is release of corticotropic releasing hormone is more. That leads to increased neuronal excitability and seizures is there. So this is the underlying proposed basic hypothesis. What are the supportive evidences for this HPA axis or CRH axis hypothesis? One is in the CSF, we find out the ACTH levels are very low. And second thing is after hormonal therapy like ACTH and steroid therapy, there is improvement is there. These through is supporting this CRH axis hypothesis. So up to now, this is how at least we have some evidence. So this is about the clinical presentation and underlying hypothesis and underlying causes of this West syndrome or epileptic spasms. So after that, our clinical very important part is the diagnosis and evaluation. So any patient come to us with the suspicious or epileptic spasms, we need to diagnose and evaluate the underlying cause. So these four, especially important is so this flow chart will give the how to approach, how to we are going to investigate these kids. So first investigation of choice is any clinical spasms, we are going to find out the EEG. After that, MRI. Based upon the MRI, if any genetic abnormalities is there, like tubers or hematomas is there, we are going to targeted genetic testing. If non-specific findings is there, evaluate with the metabolic screen. Even if the metabolic screen we are unable to find out the causes, we can think of the cryptogenic infantile spasm. So we are going to find out other the next level of the metabolic testings are genetic testings. This is the level of the tier of the investigations in case of epileptic spasms. So EEG. So EEG is here in the epileptic spasms, very important diagnostics tool. So we can diagnose the West syndrome or epileptic spasms or infantile spasm symptoms. It will useful for the prognosis purpose of the disease, and it will useful for the decide the treatment also. Next level of the treatment. So that's why EEG is very important too. So how can we do EEG? Which type of EEG is better? So if available, video EEG is better, but in the routine EEG, we can find out in the routine EEGs, these hypsarrhythmia patterns or multifocal discharges, most of the time we can find in the routine EEG. So if the child is clinical spasms is there, but with the normal EEG findings is there, we can go for the overnight prolonged EEG. So sometimes we are going to miss in the routine 30 minutes EEG. So that's why if clear-cut clinical spasms, if we have the video, if you have the clear-cut description, we can go for the overnight EEG. So is this patient need any repeat EEG? Yes, this patient needs the repeat EEG. If the first EEG is normal or inconclusive, we can go for the repeat EEG. Best to go for the overnight EEG or video EEG. So second thing is treatment purpose. So after the treatment, there is cessation of the spasms is there. So we need to find out any resolution of hypsarrhythmia or any change in the epileptiform abnormalities. We are going to do repeat EEG after 2 to 3 weeks. And sudden change in the seizure types, any new type of seizures is there, we are going to repeat EEG. Or after the treatment also, there is no clinical improvement or partial improvement, we need to go the repeat EEG. What are the EEG patterns in the West syndrome, or what are the EEG patterns in the epileptic spasms? So we have the one fancy word and one classic word, that is the hypsarrhythmia. Hips means, in the Greek word, hips means very high. So in the 1952, Gibbs and Gibbs couple described this hypsarrhythmia pattern as a simple word: random high voltage slow wave spikes is there. So this EEG have the very abnormal background activity. We are unable to identify the background activity, and very high voltage sharp waves and spikes. So after some times of this high voltage sharp waves and spikes, there is the decreasing the base, so background activity. So this is the interictal finding of this West syndrome or epileptic spasms. During the ictal attack, during the spasm, there is complete suppression of the background activity, we can notice. So interictal finding is high voltage slow waves, and ictal findings is suppression of background activity. This is the classical hypsarrhythmia findings. So, but in the practice, we are not going to this classical hypsarrhythmia patterns. We can see some modified hypsarrhythmia patterns. What are the modified hypsarrhythmia patterns? One is the TPO predominance. TPO predominance means these changes we can see in the temporoparietal hospital areas only, not in the frontal lobe. Second one is the asymmetrical patterns. Very important, this asymmetrical pattern. So one side of the hemisphere is involvement is there, and so asymmetrical spasms is there. We can see only EEG findings on one side only. So and next one is the burst suppression pattern. So burst suppression pattern also one type of modified hypsarrhythmia pattern. So in the sleep, these hypsarrhythmia pattern is increased. Luckily, in the infants, most of the time we are going to do the EEG in the sleep only. So in the during the sleep, we can find out the increased hypsarrhythmia patterns is there. What are the other abnormalities in the epileptic spasms EEG? We can see some focal epileptiform discharges. We can see especially multifocal epileptiform abnormalities we can see in this EEG pattern. So EEG is the very important tool diagnosis, treatment, and prognosis. So this is the classic hypsarrhythmia pattern we can see on the monitor. This is the same image. So depending upon the clinical and EEG findings, West syndrome is categorized into three types. One is confirmed West syndrome, probable West syndrome, and possible West syndrome. Confirmed West syndrome means home video showing cluster of spasms with hypsarrhythmia pattern of EEG. So probable West syndrome is clinical history suggestive of spasms and EEG shows other than the hypsarrhythmia patterns. We can see think of probable West syndrome. And possible West syndrome, only clinical history is doubtful of spasms and EEG is multifocal discharge. So nowadays the B and probable and possible West syndrome we are considering as the infantile spasms spectrum syndromes to find out the other causes, or we are not going to name this as the West syndrome. So only we can think of considering as the epileptic spasms only. So next mode of investigation after EEG is neuroimaging. So MRI brain is the imaging of choice. So we can find out this with the MRI brain cortical malformations, hypoglycemic brain injuries, hypoxic ischemic encephalopathy changes, tumors, hematomas, any remote stroke, Weber syndromes, and underlying this cortical malformations, pachygyria, lysencephaly. So MRI brain is the initial investigation of neuroimaging choice. If initial MRI is normal and so suspected something else, we can repeat the EEG after repeat the MRI after 3 to 6 months. But if MRI is normal, asymmetric spasms, focal EEG changes is there. Consider the PET CT to find out the hypometabolic area in that focal areas. This is about the neuroimaging. So after neuroimaging and EEG to find out the underlying other inborn errors of metabolisms or other findings, we are going to the metabolic evaluation. That is metabolic evaluation, blood glucose levels and ABG. Very important thing is compulsory we need to find out the biotinidase deficiency. Any infantile spasms kid, any epilepsy, any infantile epilepsy, we need to rule out the biotinidase deficiency because we have the very good treatment. With the treatment, we have the very good prognosis. If we find out as early as possible, we can prevent the neurological morbidity also. And go for the serum ammonia, lactate, and TMS and GCMS to find out the underlying IEMs. Second, after all these investigations is normal and MRI normal, we can go for the rule out of some lysosomal storage disorders, fatty acid storage disorders, and last is the hyperglycemia. That is, we need to go for the CSF glycine, lactate pyruvate ratio, and CSF neuro. These are very costly investigations, not available in everywhere, and we need to send these investigations with particular precautions. So storage and transport is very important in CSF glycine and CSF neurotransmitters. So these are the metabolic investigations to find out the underlying metabolic causes. After that, metabolic investigations also are if any child have the syndromic features with West syndrome, we need to send for the find out the karyotyping. So already I mentioned Down syndrome kids can also have this West syndrome or epileptic spasms. Find out the fish and microarray also. So if any syndromic features is there, we can go through these three investigations. If non-syndromic features is there, send for the CES. This is clinical exome sequencing or whole exome sequence. If specific, if the child have the clinical findings of tuberous sclerosis like adenoma seborrheic and that ash leaf nodules, all those things we can send for the TCS genes directly, or any Weber syndromes. Any neurocutaneous markers is there, we can send directly to Weber syndrome. Specific genetic testing is there. So these four are the to find out the evaluation and to find out the underlying cause and plan the treatment protocol for this epileptic spasms. So now we are going to the treatment part. So important is there, start as early as possible. So many studies and so much evidence is there. If we start the treatment less than 3 weeks of time, we can get the good results and good prognosis. I already mentioned about cryptogenic West syndrome, how the good respond well and less neurological morbidities is there. So this is the guidelines in India, consensus guidelines released from the Association of Child Neurology with combination of Infantile Epilepsy Society. So they released some consensus guidelines based up. So this is published in the Indian Pediatrics in the I think January something 2021. So what are the drugs? There are two type of drugs: is first line drugs and second line drugs. Here, West syndrome is we are considering as the epilepsy, but our treatment is very specific. We are using the hormonal therapy because I already explained that is CRH excess hypothesis is there. So hormonal therapy, after that vigabatrin. Second line medications are pyridoxine, benzodiazepines, valproic acid, lamotrigine, are all those anti-seizure medications. So these hormonal therapy also very specific for this condition. We need to use very cautious. We need to discuss with the parents before going to start this therapy. So ACTH hormonal therapy consists of ACTH and prednisolone. So natural ACTH is very costly. Most of that are not available in India. Synthetic ACTH we are using. So mechanism of action exactly we don't know, but this is very useful. Dosage are variable according to the variable institutes and variable societies. High dose regimen is there, low dose regimen is there. Route is deep IM route is there, subcutaneous route. Most of the institution using the deep intramuscular route only. So dosage for we are using, I am also using high dose regimen. So what is the dosage? Very important. 150 international units per meter square body surface area or 6 international units per kg. So initially OD dose for 2 weeks as a morning dose in the deep IM. After that alternate day for 2 weeks. At the end of the 2 weeks, so clinical cessation of spasms and EEG resolution we need to assess. So this is the classical dosage regimen, that is total is 21 dosage. Some will use the low dose therapy that starts with the 10 to 20 international units per day. So gradually they increase up for 4 weeks. After that taper the 4 weeks. So this is almost 9 weeks or 10 weeks therapy is there for low dose regimen. So before starting these therapies as well, anywhere when we are going to start the steroids, we need to rule out the tuberculosis in our India. So check for the chest X-ray and Montos test and ESR. So monitors. So we know these steroids have the so many systemic side effects like hyperglycemia and hypertension, all other those things, weight gain, all these days. So monitor for GRBS and blood pressures, and there are high chances of gastritis is there. We can advise for the proton pump inhibitors or antacids for this patient along with the high dose regimens or low dose regimens. So what is the dose of the prednisolone, oral prednisolone? So this is called as high dose prednisolone therapy. So we need to start from 2 to 8 milligrams per kg per day. OD dose or sometimes we can use the multiple doses. So after that gradual tapering is there. Usually start with the 2 mg per kg per day up to 8 mg per kg per day. Most of the time I use the preferable dosage is 4 mg per kg per day. So when we are using for some allergic conditions, some asthma or nephrotic syndrome, our dosage is almost 1 mg per kg per day. Here 4 mg per kg per day. So this is a specific dosage. High chances of getting the side effects is there. So council clearly regard this dosage. So one practical problem I faced personally. So many of when I started this 4 mg per kg per day, after 1 week or 5 days, they used to stop because someone will tell this is very high dose. So you are using very high dose steroids. So they used to stop this dosage medications, or they will give suboptimal dose that will give the poor or improper response of the spasms. So when we are prescribing the dosage, clear-cutly discuss with the parents and write on the prescription pad, don't decrease or don't increase the dose, and use according to our protocol. So this is the practical problem we are facing when we are prescribing high dose prednisolone. So which is better, ACTH is better or steroid is better? So according to the studies, both have the similar efficacy and similar adverse effect profile. So we can choose initial choice of drug. We can choose depending upon the treating neurologist and depending upon the family cost and availability of the drug and person to give the IM injection. So usually I practice, if any patient coming near to me from the nearby our area and they have the facility to give IM injection, I used to prefer high dose ACTH therapy only. If they are coming from the remote areas, at the time ACTH each injection can come used for say 5 to 6 doses and they need to keep in the fridge. So after 6 doses, this ACTH is not available in everywhere. So they will discontinue the therapy. That will give the improper treatment, improper response to the therapy. So in any remote areas patients is coming, I used to give the oral prednisolone therapies. So if oral steroid therapy is respond is failed, we can go for the high dose ACTH therapy. If initially if you start the oral steroids, high dose ACTH is preferable therapeutic option compared to the low dose ACTH, because high dose ACTH have less injections, less dosage regimen, and low dose ACTH have the we need to give the so many doses. So that's why high dose ACTH is preferable therapeutic option. If even after this hormonal therapy there is no clinical spasm cessation or persistence of hypoxic hypsarrhythmia, we go taper the ongoing drug and start the other drugs. So this is, so most of the time I used to prefer the high dose ACTH in my clinic and my practice. So recent one clinical very big study released, results are released, conclusion is that is IC studies. Previously one UK study is there, now this is the IC studies. According to IC studies, hormonal therapy with vigabatrin so is significantly more effective at stopping of the spasms than the monotherapy, hormonal therapy alone. So since last 1 year or 6 months, we are using this combination of hormonal therapy with vigabatrin. So nowadays vigabatrin is available in India. Previously not going to available in India very frequently. So nowadays most of the time we are using this therapy. So what about the vigabatrin? So vigabatrin, when we can use the vigabatrin as first line? According to this study, so many are nowadays using vigabatrin as first line also. So when there is the clear-cut tuberous sclerosis complex is their first line therapy of infantile spasms is vigabatrin. Failure of hormonal therapy, any contraindications for the steroids, at that time we can use the vigabatrin. So dosage, we can start with the 50 mg per kg, hiked every 3 to 7 days, 50 mg per kg, up to maximum is 150, or cessation of the spasms or effective of the spasms, which is earlier. So maximum within the 14 days. So if therapy is effective, we can use up to the 6 months. So main concern about this vigabatrin is visual field defect. Ideally, we need to check visual fields before initiation of the therapy and intermittently also. But so many times in the practically we're seeing very less cases of visual field defects compared to the benefit. This risk is very less. So in India now these 500 mg powder from sachets are available with vigabatrin. So we are using vigabatrin as a well commonly. So we started hormonal therapy and vigabatrin. So and reassess after 2 to 3 weeks. After 2 weeks reassessment, there is complete cessation of the spasms is there, and hypsarrhythmia pattern also resolution is there. What can we do next? How can you plan the next treatment options? So treatment after electroclinical resolution. If EEG is completely normal, taper the hormonal therapy. When ACTH is there, I used to stop within the 2 weeks. If steroid is there for like 4 weeks like that, we can taper the hormonal therapy. There is no need of any anti-seizure medications. If EEG is showing some other epileptiform abnormalities, we can start the anti-seizure medication along with the tapering of this medication. So in the anti-seizure medication, which is best drug? So there is no clear-cut evidence, but most of the time we use the valproic acid, after that jonissamide or topiramate also. So there is the 10 to 15% of relapse of this spasms is there. So if the relapse is there, we can try a second trial of the hormonal therapy or vigabatrin is there. So even hormonal therapy, even this vigabatrin therapy, there is no resolution of the clinical and electrical resolution is not there. We can consider anti-seizure medications. Those valproic acid or benzodiazepines like clonazepam or nitrazepam, jonissamide and topiramate. So pyridoxine dependent epilepsy also we can consider. So we can try with the pyridoxine and pyridoxal 5-phosphate folic acid for 1 to 2 weeks. So if 1 to 2 weeks any resolution and improvement is there, we will continue. In the Japan-like countries, the pyridoxine they will start as early as possible. In the Japan-like countries, pyridoxine is the initial choice of therapy also. Even biotin also we can consider, and anyway in the metabolic evaluation we must rule out the biotinidase deficiency, and no response with these medications also we can use the diet therapy, that is ketogenic diet, and surgery also there is options is there. So this is after the 2 weeks of 3 weeks of therapy, this is the next line therapy options is there. So very important point, within the 1 week of initiation of treatment, so many patients there is spasms are stopped. So and EEG improvement also there. That's why we used to do the EEG after 2 weeks. So outcome of these patients, variable outcome, that is depending upon the underlying cause. Second very important thing is initiation of the treatment after starting of the symptoms. So there is a high risk of intellectual disability, risk of autism is there in these patients. So at the early preschool years, these multifocal discharges and resolution of these EEG abnormalities is there in the majority of the patients. But 50 to 90%, almost 50 to 90% of patients develop other seizure types. So that's why this is the very important. We need to identify as early as possible. In this 27 to 50% patient converted into Lennox-Gastaut syndrome, other into the focal multifocal epilepsy. Once they are converted into the Lennox-Gastaut syndrome, very hard to control the seizures. So this is the chronic epileptic condition. So one important thing is initiate the treatment very early. So this is all about the how can we identify the spasms, how can we treat the spasms, how can we evaluate the spasms. Last is the take-home message. One is the remember, this is the rare condition and unique condition have the specific treatment. So not like all other epilepsies, this have the specific treatment, that is hormonal therapy. So variable etiology, this is not the single entity. So variable etiological causes from the prenatal to natal to postnatal conditions. And we need to very important take home message for this session is identify the risk groups. What are the risk groups? That is any child with the NICU admissions, any child with neonatal hypoglycemic or hypoglycemic brain injuries, or neonatal meningitis, prolonged NICUs and IVH during the NICU stay, or any dysmorphic kids. These are the and tuberous sclerosis children. These are the high risk groups. Any high risk group have the subtle spasms, we can go for the EEG. So so second thing is one more recommendation from my side is our side is inform the parents about the clinical spasm. Any NICU graduate discharging from the NICU, we will counsel about the retinopathy of prematurity, we will counsel about the audiological evaluation, we will counsel about the regular neurodevelopmental assessment. At the same time, we need to describe or we need to counsel about the spasms or development of the seizures also. Anyway, most of the meningitis or HIE or hypoglycemic brain injury patients have some anti-epileptic medications. So at that time, we need to describe about these spasms. So we can describe about the classic presentation of the spasms to the parents, and at that time they can consult us very early. So any suspicious, we can go advise for the EEG. Early treatment have the early remission and less morbidity. So treatment is very specific. That's why we need to recommend the scheduled treatment, completely discuss with the side effects and protocolized treatment, standardized treatment, that is important. Educate about the adverse effect, because we are using the specific drugs, CTH and steroids and vigabatrin. We need to educate about the adverse effects. So here adverse effects are these benefits are more compared to the adverse effects. So overall, my main message is identify the risk groups and educate the risk group parents before the onset of the spasms. That is my take home message during this webinar. So this I already told, this December 1 to 7 is the infantile spasms awareness weeks. So stop. One is the sign, identify the signs, take the video, obtain the EEG and prioritize the treatment. This is the start. So this is all about the infantile spasms and West syndrome. So thank you.
Thank you very much, sir, for this nice presentation. Just give me 1 minute time, sir, to check the questions. Already I have received 1 or 2 questions, but as in the speaker link also, I could see that many doctors have also joined. So first, I would like to request all the doctors who have joined in this link. So if you have any query, you can directly ask sir, or you can post in this chat box. So any question from your end? So directly you can unmute yourself, and if you have any queries, you can ask. Okay, meanwhile, sir, I have received one question that if a child has a colic episodes in very frequent intervals, then this means does this needs to be investigated? Or what is your suggestion on that?
What the question?
Sir, if a child has colic episodes in very frequent intervals, then what will be your diagnosis approach, or what parameters should we keep in mind?
So first is the important thing is the EEG. So EEG is the very important thing in any episodes like this episodes. EEG is the very important thing. So at the same time, we need to identify underlying cause, go for the neuroimaging. But with the EEG, is this events are related to the epileptic spasms or West syndrome? We need to identify. So anywhere EEG is the very important investigation of choice in these cases.
Thank you very much, sir. Sir, another question is, does this epileptic spasms goes away, or is it remain or can transform into some other epileptic conditions?
Yeah, sure. Obviously, I already mentioned about this thing. So in my last slide, there is 50 to 70%, almost 50 to 70% of children develop other type of seizures. So especially any symptomatic in epileptic spasms going into the other type, that may be one very bad epileptic condition, that is the Lennox-Gastaut syndrome, which is very drug resistant condition. Other can have the tonic seizures or some multifocal seizures or like that is there. So that's why 50 to 70% high chances of getting the other type of epilepsies, other type of seizures. These West syndrome or in epileptic spasms are very limited to some time, that may be 2 months or 3 months or 5 months. But when we treat it as early as possible, we can prevent the further developing of the other epilepsy conditions.
Thank you. Thank you. Thank you very much, sir. And sir, a few studies also suggest that there is some correlation between this infantile epilepsy and this circadian rhythm disturbance. So what
Yes.
suggestion on that?
That is there. That's why circadian rhythm, because our main hypothesis is HPA axis hypothesis. HPA axis hypothesis may depending upon the circadian rhythm also. That's why most of the time we are giving these ACTH therapies and these prednisolone therapies according to that. Most of the time morning dosage and single dosage. This is all related to circadian rhythm and HPA axis and infantile spasms. So the dosage also, OD doses, morning dose is also decided by the circadian rhythm changes. Yes.
Sir, another question I received that from Dr. Prasanthi Reddy, that prognosis and complications in untreated cases.
Yeah, untreated cases, whatever the data is there, untreated cases will have the almost 90 to 95% of development of intellectual disability, autisms, and chronic epileptic conditions is there. So untreated, almost every case of untreated cases going to develop this, any one of these neurological morbidity is there. Most of the time untreated cases have the very high chances of other epileptic conditions. If you treat or untreat, these West syndrome means spasms will decrease after some time. So most of the time we are practically we are seeing, they will tell at the time of 6 months, 7 months, child have the jerks for 2 to 3 months. After that, they're subsided. They are treated with some other anti-epileptic medications. These spasms are decreased. So we can see these cases very frequently. When child came to me at the around of 3 years of age, when I go through the history, this child have the multiple episodes of seizures and multifocal seizures. At the time, while we are going to inquire about this, at the time they will tell. So NICU stage is there, 6 to 9 months of age, they have the spasms, but they are not treated. So they can feel these are some fearful movements, they are non-epileptic movements. So after some time they will decrease, but they are not taken proper treatment. This brain is going into the chronic epileptic condition, that is LGS or other epileptic condition. They can have the global developmental delays, autistic features, all those things is there. So we can see very commonly in our location. So unrecognized West syndromes or unrecognized West syndrome converted into the chronic epileptic conditions. We can see, we are seeing also. Yes.
Thank you, thank you. And that means, sir, it is also related to this. Sometimes it can be correlated with the autism itself.
Yeah,
So
because
is
autism also, so many these epilepsies, underlying epilepsies can have the behavioral issues. In that behavioral issues, autism also one behavioral issues, particularly related to the West syndrome.
Yes, sir. And sir, as you also mentioned that there is some disturbance in this circadian rhythm. So, sir, melatonin is sometimes used. So, what is your practical experience? Does it have any role to regulate this spasm in terms of maintaining this circadian rhythm?
So any spasms kid is there, they can have the high irritability and sleep disturbances is there. We are regularly using the melatonin. So melatonin will give the very relaxed to these patients, and they can have the good sleep. At that time, they can have the good improvement also there, and cessation of the spasms and decreasing the irritability and acquiring these milestones back is very good compared to the other medications and melatonin. We are using melatonin very combination with melatonin. We are using very commonly in these cases.
Thank you.
Very good drug. Melatonin is very good drug for these patients. We have the irritability and sleep issues. Most of the patient with the spasms, they have the sleep issues.
So, sir, in that case, what will be the doses of this melatonin? And at what doses you generally prefer to do that?
So, if patient coming to me after 1 month of spasms and the child has completely disturbed sleep, completely irritable, I used to start 5 ml, that is 3 mg.
3 mg.
Yeah, 5 ml, 3 mg. Sometimes I can start with the 2.5 ml, try it for 1 week. If there is no response with the ACTH or hormonal therapy and this 2.5 ml melatonin, I increase the dose of this melatonin along with the other treatment options. So most of the time I use to 2.5 ml, that is fine, 1.5 mg, because these are all less than 10 kgs. Most of the babies less than 10 kgs.
Sure. And one question, sir, more, that is any cutoff. We have received this in Facebook also. There is any cutoff in episodes for undertaking this EEG. So, is there any cutoff in episodes?
Cutoff in episodes.
Yeah.
So cutoff, I can't understand clear cutly, but we have the hypsarrhythmia pattern. Changing in the hypsarrhythmia pattern, we can see.
And sir, what I guess this from this question, so is there any number of episodes that after that number of episodes only we can have this EEG and to understand this EEG? So that is why maybe
quantitative. I think that is question related to quantitative details.
Yes. What I fix
quantitative details. Quantitative details related to the episodes and hypsarrhythmia patterns are nowadays, because we need to find out the quantitative details, need video EEGs, continuous video EEGs or prolonged video EEGs is there. So some studies is going on, but most of the time in India, video EEG availability is very, very less. So I think Hyderabad are metropolitan cities and well-developed neurological centers, there is no video EEG available, but there is studies are going on. Yeah, in our setups like Warangal and Hyderabad and so many centers, we can find out these spasms with the routine EEG. Most of the time routine EEG. So very less likely we need overnight EEG also, because in initial stages, if subtle spasms is there, at that time we need overnight EEG. But otherwise we can go for the routine EEG. We can identify quantitative data. They are trying to get the quantitative data to find out the prognosis purpose of the West syndrome, but only for research purpose they are using all this data. Yes.
And infants are one question. Infants, if treated with such high dose of steroids, and when vaccines are also contraindicated, so how the risk of infections?
Yes, this is a very practical problem. So vaccination and ACTH. So we usually recommend completely stop the vaccinations or immunization during the steroid therapy and ACTH therapy. After complete stoppage of the steroids or ACTH, after 1 month, minimum duration of the 1 month, we can advise for these medical vaccines, at least minimum 1 month. That is recommended. Our consensus guidelines also mentioned about this 1 month minimal gap between the stoppage of the therapy or ACTH or steroid and vaccination. So we need to stop the vaccines during the therapy after 1 month of the therapy also. Yeah.
Thank you very much, sir. Society, is there any other questions?
No, sir.
So in the chat box also, we could not see any other questions. Okay, so thank you very much, sir, for such a wonderful discussion on this very important topic, and obviously for thanks for your valuable time to discuss this. So in future also, we will look forward for some valuable session with you, sir. So thank you very much, sir.
Thank you. Thank you to all the
Sir.
participants. Thank you.
Thank you. Thank you. Thank you.